So thank you all for coming. We are excited to have our very good friend Victor Rodriquez from the Tacoma Pierce County Health Department with us, and he's going to talk about evidence-based practices in public health and some of the initiatives they've been working on with the Triple P project, the Positive Parenting Program. So just a little bit about Victor. He is an MSW and then the program manager for the Strengthening Families Division of the Tacoma Pierce County Health Department. He's got about 15 years of experience in social work, grassroots community organizing, and public health. He has worked with children and families directly through evidence-based programs as well as community-driven programming. Mr. Rodriguez has dedicated his personal and professional life towards achieving equity and social justice. And just one more little announcement. If you guys weren't able to sign in or grab an evaluation form, we would appreciate you doing that before you leave. And if you have any questions, let Victor know, and I'm hoping he's going to repeat them in the microphone so we can catch your answers and all that information as they're recording them. Okay?
Thank you.
All right.
Thank you. All right. Hi, everyone. Thank you for coming and listening to me talk. It's pretty awesome. And so my name's Victor. A little bit about me. I grew up in Skagit County. I was born in Texas, raised in Mexico, and then raised the rest of my life from 7 years old all the way up to like 26 in Skagit County. So I'm son of two farm workers who worked the Skagit County fields, the tulip festival, strawberries, cucumbers. We did it all. In fact, my parents still work in the farms, and I always share with that, always open with that. For one, to honor my parents and the work that they did. Because if it wasn't for them, I wouldn't be here right now. And then also because that's really the foundation. That's what drives me, and that's what the lens that I use when I approach my work. So that's where I come from, right? So today we're gonna present what's called evidence-based practice in public health, and there's two parts to it. The first part is talking about the project, the Triple P Urban Initiative, which is a partnership between the University of Washington and the DBHR, and I don't know what that stands for, Department of Behavioral Health and Recovery. There you go.
You had 3 of the 4.
That's pretty good. And then the other part is talking about my personal experience working on evidence-based programs from a grassroots organizing perspective, and how it interfaced and how I interconnect or worked with evidence-based programs from that perspective, and some of the barriers that came along with trying to work within the framework of evidence-based programs from a community organizing kind of perspective. So the first part we'll share is a little bit about the Triple P Urban Initiative, and any questions? Thus far, I like to be participatory, so I know we're going to wait to the very end for questions, but if there's questions along the way, just ask, and we'll just kind of hang out together and have a cool conversation. So I'm the program manager for the Family Support Partnership that's within the Strengthening Families Division, and the Family Support Partnership is a partner-driven effort to assure safe, stable, nurturing relationships and environments for all children and families. And it's a collaboration with partners across Pierce County. So, we partner with school districts, nonprofits, the health department, to support 6 family support centers. And these family support centers are located throughout the county, some in the rural communities, some in the urban community, in the urban setting. And these centers have been around for quite a bit of time, for like 25 years. And the goal of these centers is to be a hub for the community, a place where people can come and get services and support, that's the Family Support Partnership. And I actually started working there actually in April, and since I've been there, there's been a lot of changes happening with this program. And one of them is that we're using the Essentials for Childhood framework to approach the work. So Essentials for Childhood is a CDC framework, and it's an evidence-based approach to addressing child maltreatment. And it encourages communities to kind of adopt this vision of making sure that children have safe, stable, and nurturing relationships and environments. And I'm probably preaching to the choir as to why relationships and environments are critical for not only preventing child maltreatment, but just for promoting health in general for everyone, right? And then provide 4 steps on how to achieve that and how to get there, right? So raising awareness and commitment, obviously, getting community committed to addressing child maltreatment and to supporting children's health and families, right? And then using data to inform the work that we do. And the other one is norms, changes, and programs, which is actually where the triple P kind of work falls into. And then the other one is creating the context through policies, right? So it's not just about getting individuals to change their behavior, but also understanding the context, right? So we could tell someone, for example, or a mom, we could say, oh, it's really important for you to breastfeed. Here's all the research that shows that, right? And I always use my own sister as an example. So me and my partner just had a baby. He's 1 year and 3 months. And, we both work in public health, so, we're breastfeeding all the way. She still breastfeeds. We're like, hell yeah, breastfeeding. Of course, why wouldn't you, right? So my sister just had a baby not that long ago. I want to say probably like 6-7 months ago. And so I was telling her, I was like, yeah, this is a breastfeeding. I gave her pamphlets, just everything that I could share with her about the importance of breastfeeding. The difference is that my partner and I work at an institution that gives us time. So my partner at the time worked at the Department of Health, so she got time to go. She actually a special room where she can go and pump. And actually now they just passed a policy that allows children or allows moms to bring their children up to 6 months into work. And actually the health department is actually our health department is also piloting that, right? And my sister, on the other hand, she works at a gasoline station. She works part-time. And in fact, when she got pregnant, she was almost like being pushed out for her to quit because her employer didn't want to give her time off, right? So when I told her you should breastfeed, she was like, well, actually I have to go back to work 2 weeks after I give birth because one, I don't make enough money to be able to take off all that 6 months. And two, I can't breastfeed at my job because my job actually doesn't support that. So it's just an example of like we can encourage that individual behavior, but if we don't actually create the context to make that behavior actually doable, it's going to be really hard to maximize the results, right? So that's why it's norm changes and programs at the same time creating a context for that, right? And here's kind of a visual of what that might look like, right? So. At the very top, you have your parent training, for example, your counseling, your education, and as you go down, you have clinical interventions, you have your long-lasting protective interventions, right? And then you go down to the context that I was talking about, and even below that, you have your socioeconomic factors, right? That profoundly impact people's ability to parent and to implement the kinds of behaviors that we know lead to positive health outcomes, right? So we're approaching, this is how the Family Support Partnership understands and approaches reducing child maltreatment. That it is providing parents with that individual training and support, but it's also at the same time creating a context of policies and norm changes. And triple P and most evidence-based programs stay up here, right? You don't see it? They usually stay up here, right? Most evidence programs stay up here, and I hardly ever, I don't know of any that really actually go down here. And that's actually one of the cool things about the Triple P Urban Initiative, right? That it actually, this is evidence-based program that does this, but actually gets into this area down here about community norms, right? It actually starts to broaden the amount of people that it reaches. It's not just one-on-one, and I'll talk a little bit about how it does that in just a sec. Any questions about that? Make sense? Okay, cool. We have different kinds of strategies that we use to reduce child maltreatment to promote child health. One core strategy is parenting, right? Why? Because of all the obvious reasons we already know. Parenting informs every phase of a child's development, right? From the early years, it's really important for developing secure attachment, language, right? And it just that relationship earlier on from mom, right, and dad, right? Let's not forget the dads. We're important too. We have an impact too. But mom specifically, right? It's like that bond creates the foundation for emotional health, for physical health, right? For mental health later on. And that importance of parenting is true throughout life. Even now, right? Like I still, lean on my mom for advice, or I still depend on my family and my parents in certain ways, right? So parents are just a critical role, play a critical role in health, right? So if we know that, and if we want to have an impact on children's health, then going through parents and supporting parents is a critical step to achieving that. So, so some of the things that we do at the Family Support Partnership is, one, we offer, and let me back up a little bit. So our role in the Family Support Partnership and the Family Support Centers is actually not providing direct service, but our role is funding and providing capacity and training. So we fund 10 or 12 home visitors. So we contract out with community organizations and then hire home visitors. These home visitors are trained in Triple P Level 4, and I'll explain a little bit what that means. And are also trained in promoting first relationships, which is another evidence-based program that helps parents or that teaches parents and provides trainings to parents on how to build strong relationships with their children. In addition to that, they provide like just kind of general case management and more than anything, I always say this, I feel like a key and a core of what they provide is that relationship, that trusting relationship, right? That non-judgmental relationship, that person that can count on when it gets hard, right? That oftentimes, unfortunately, might not be something they have in their lives, right? So that's kind of some of the things that the home visitors provide. So now I'll go into talking about the Triple P Urban Initiative. And there's actually folks here that are part of that initiative too. So if I miss things and there's things important that I missed, please join and help me. And but Triple P Urban Initiative, the goal is to building a robust behavioral health services network in Pierce County. And like I mentioned before, it's a partnership between the UW and then DBHR and the health department and other organizations that are in the community. But these are the kind of the core partners that are planning and implementing this. The way we're doing that, the way we're developing this network is we're training primary care providers, mental health providers, family support workers or home visitors in Triple P Level 2 and Level 4. And we also trained other folks like librarians and there was like folks for the museum. I don't remember on top of my head all the different kind of folks that we trained, but we trained like over 70 people already. So it's and different levels of Triple P. And a key part of that is also too making sure that the medical system, right, is communicating and talking to community services, right, to the community, right. So like home visitors, the folks that are dealing with housing issues, all the kinds of things that also impact families, but that oftentimes are not necessarily addressed directly within a primary care kind of visit, right? So making sure that those systems are integrated and talking and communicating. And Triple P is kind of like the thread that we're using that's kind of connecting those, right? So let me see, what's the next slide? Okay, this is the next slide. Okay, so this is the Triple P system, and this is kind of what it allows the Triple P, and I don't think I've even said it, Triple P Positive Parenting Program. How many of you have heard of this? Oh, it's most people. Okay, man, y'all didn't even need me to explain it. So Positive Parenting Program kind of has these different levels, and it's what it allows it to have a population kind of impact, right? So you have like the level 1, right? Is really like broad communication, right? So billboards, commercials, social media, right? Just like your broad communication that reaches a bunch of people around positive parenting and the positive impact it can have with little children. And as you go up further, right, it intensifies, right? And so when you implement all these at once, right, you actually, that's how you're able to reach a array of folks, right? So some folks just need maybe a tip around how to get the children to go to sleep, right? But some parents might need a lot more support in dealing with maybe some more severe behavioral issues, right? So this kind of system, the way it's set up, is what it allows kind of a public health approach to child maltreatment, right? And I'm not going to go into this now, but there is some kind of evidence that's based on some work that was done. It was at Kansas. I always say Kansas. I don't know. South Carolina. I always say Kansas. I don't know why. South Carolina. They implemented this here, and they actually saw population measures move, right? By basically saturating a community with providers trained in all these different levels, right? And for us, right, if you remember in the Successful Charter framework, one of the strategies was changing norms, right? So this for us is a strategy to actually start changing norms about parenting, right? So that parent support is not something that only parents that are either bad parents or only the parents that need help should get a program. But we all need help. Like I said, me and my partner, we don't necessarily fit the criteria for someone that might need an intervention. But man, we need some help. You know what I'm saying? Like it's hard, right? So part of this is not just waiting until it gets severe. Is that prevention part. So this system allows to reach people like me who just need general support about how to deal with, kind of normal kind of behavior, all the way up to level 5 or level 4, where it's, children that are experiencing more difficulty around some behavior issues, right? Let's see here. Triple P, as you know, is backed by over 33 years of research, and so it's been well documented that it works. Let's see here. Okay. So through this grant that we've got from DBHR, we have been able to train folks on these levels right here. So level 2, pre-primary care, level 2 seminar, level 4 standard, level 4 group, and the PCS 17 is also a screen that primary care providers were trained on that they use. So I'll explain a little bit about how it works. So this is kind of the trajectory of how it works, right? So I'm a mom. Okay, more realistically, I'm a dad, right? I come in, right, for a well child visit, right? For a regular child visit, and then I get to screen, right? And then from the screening, doctor in conversation with the parent decide, hey, you know what? You might benefit from a level 2 parenting. Would you like something like that? And level 2 is a brief conversation, 15 to 30 minutes about parenting tips, right? And they get a tip sheet, and then they also come up with a couple strategies they can implement. And it's also followed up by a phone call, right? About, hey, how did that go, right? So very brief. It's not very intensive, and those are intended for parents that just don't need that much support. They just need just a little bit, right? But however, there's going to be some parents that need more than that. So at that point, that's when they refer to for FSP. FSP is Family Support Partnership, and that's the program that I manage, which is the program that partners with folks to have the home visitors and the family support centers in the community. So the primary care screens them, says, hey, you can use more help. They refer them to a home visitor, and the home visitor contacts them within 72 hours and goes to their home and does Triple P level 4. And Triple P level 4 is more extensive. It's 10 weeks, and they go into the parent's home and they go through these different sessions around different topics related to parenting. And particularly really promoting a positive approach to behavior, right? Really encouraging the positive behavior in children and developing tools on how to deal with not so positive kinds of behaviors. But it's one-on-one, right? And it's for 10 weeks at least. And so it's a little more extensive. Now at that point, home visitors also are looking to see if maybe the family needs a little more support, right? Maybe it's not just that the parent needs more tips around how to handle the behavior. Maybe it's actually that the child actually needs some mental health services and mental health support, right? So we're probably halfway into this project, right? So this year we're going to train 20 primary care providers, or up to roughly about 20, not primary care providers, mental health providers on level 4 as well, Triple P level 4. And so that when home visitors and the families, as they work together, decide that actually they need more than just parenting advice, right? They actually need some mental health kind of services, then they have mental health providers that they can refer them to. And kind of the bigger picture here really is creating the conditions and opportunities for these providers to provide coordinated care, right? So that they're communicating with one another. And the home visitor plays a key role in that, because the home visitor is probably the one that, not probably, is the one that kind of facilitates navigating some of those systems, right? But eventually, right, we want, those folks are communicating, these folks are communicating, but we want the communication to be, this way and this way, right? That all folks are communicating at some level. And that's important for one, it's more efficient, right? And two, it's easier for parents, right? So that parents are not getting mixed messages, one. And two, that you don't have a doctor working on some goals, and then you have mental health working on different goals, and then you have a home visitor working on different goals, right? But instead, there's a core set of goals that the family's identified, and you have a team that's helping them support that, right? So it's kind of like, it's a medical home model, but it's taking it out to the community. And in fact, there's actually a model that we like to use, or that we are striving to achieve, right? And it's called a community health home. And it's basically integrating a medical home model with community prevention, right? So integrating public health approaches and community level prevention strategies with coordinated care, right? And that's, I think, important to really maximize impact. So that's, in a nutshell, right, kind of what the program, or how we're using Triple P in Tacoma Pierce County. And right now it's mostly focused, or actually it is focused on Tacoma, and because this grant's really looking at how this might work in an urban setting. So yeah, did I miss anything, guys? Scott, Sue? Oh yeah, okay, yes. So I'm gonna steal one of Sue's talking points, because she always uses this, and I always thought it was a very powerful way to describe it. That doctors are on the top 3 of who parents describe as something they can trust to ask questions, and the other 2 is faith and family. So think about that, right? So when you ask parents, hey, when you have an issue, who do you talk to? One of the people they say is a doctor, right? Which is pretty amazing. So that's one reason, is that doctors seem to be a trusted place that parents go to when they need help around something. And then the other is just they're on the front lines, right? So when children have to go to well-child visits, immunizations, all those things that, like, for example, like us, like my family, like I was mentioning before, we don't not necessarily looking out for services, right? There's not like a community system that helps parents. You basically, you go, you have birth, and you take a class, and they're like, all right, good luck, right? Like there's nothing really out there that's really structured for parents, right? So, so the primary care providers are at the front lines. They see a huge amount of parents. So they're a good opportunity to screen, right? And to refer if necessary, and to offer support, right? So that's one key as to why primary care providers are a key role. Yes?
It's very surprising that primary caregiver is actually the one of the 3 people that people go to. Is that because like the clients that I'm seeing in the homeless population or low income, the access to doctor and healthcare is very, very scarce. And then so the people that you ask is who are those people?
That's a good question, and I don't know because I stole it from Sue. But I think that's a fair question. Of course, not undocumented families probably won't say doctors. That's the truth, right? But generally, if you look at the general population, primary care providers seem to be someone that they could talk to. But I completely agree. There's subgroups that are not going to see anyone within any kind of system as someone they go to, right? And you name some of them. Undocumented families is another, right? So yes, great point. Yeah.
Would you say a couple words about how your treatment procedures enlist the aid of primary care providers and how they train them to do the right thing?
Can you say that again?
How you get docs to do this? How you get healthcare providers to be interested in doing what you want them to do as opposed to?
It's really hard, and basically, just got to be in the hustle. No, that's actually one of the challenges of this project, right? Engaging primary care providers, because they have so many things on their plate. They already fill out 1,000 papers, right? They're so strapped for time. It's been really difficult. That's been one of the biggest challenges in this whole project. So far, we've gotten I want to say 18 or 20, I think, primary care providers, and then we have another training in level 2. So the way we've done it is we try everything. We send emails, we send phone calls, we set up meetings, we find that contact person that we can connect to, right? People that we already know, and then either we'll do one-on-ones, we do phone calls, we do presentations to everyone, we go during their lunch. We actually went yesterday to one of that. So we do all kinds of things. Yes, you know what? Did I include it in here? I didn't. Okay. I talk about the vaginal corner. Yeah, so some of the things that some of the sell points is, one, the triple P intervention is actually billable with Medicaid eligible clients. So that's one. Two, they get CMEs, right? Three, the training's free. So the part of this grant, they get a free training, which is pretty expensive. And then they get implementation materials through the grant period. And on top of that, they also get access to a referral, right? Because oftentimes that's one of the things that they say is like, well, we don't want to do that because then what are we going to do after we ask these questions? We can't help them. So then we also offer that referral system. And that referral system, we actually, part of this project, we allowed us to go online. And so we made it as easy as possible for them. But it's not easy, and I don't want to, romanticize like we're getting all the primary care providers in the world. I think that my sense that generally most primary care providers get it and conceptually, and they're like, yes. And then there's just a lot of practical barriers because their system is not set up to actually yet, right? And this is what this is about. And so this is really a pilot project. We're seeing, well, how can we make this happen? I know at the state level, and Scott can attest to, there's a lot of conversations about system integration. And it sounds real sexy, right? Like integrating systems, like, damn, man, that's cool, right? But then how do you actually do that? Like, what does that even mean to a person actually providing services, thinking about integrating systems? That's not very clear, and I don't think that anyone has an answer yet. And this is really exploring what that means. I think part of integrating systems, one key thing is making sure that people are talking, right? And that they're using common language and that they're using common messaging, right? And another one is probably around structural and figure out how medical records can be shared without compromising privacy issues, right? So there's different aspects to it, but I think that there's still a long ways to go. But this, I think that the cool thing about this is that Triple P offers that, like I said before, that thread, right? When we're training these different folks on the same kind of concept, different levels, but same concept, kind of allows a thread that kind of allows for that communication to happen. Yes?
Do a PSC 17, then add on 10 to 15 minutes, oh, there's a problem. Let's spend some time talking about that. You mentioned it's billable. Is it actually billable as a separate thing, or are you coaching them about how to use ENN codes and time-based?
It's a separate thing.
It is.
Right, so it's its own billable thing.
And your providers who are doing this, are they generally extending their visit when they've got a positive, or are they rescheduling?
It varies. I think that each clinic is different, and each clinic kind of adapts it to their setting. And I think some doctors probably just do it there, or some doctors schedule another visit. The way that the billing is by time, so it depends on how much time they spent, and then that kind of dictates how much money they get. Correct me if I'm wrong. Is that okay? Yeah, so each clinic's different, and because it's a pilot, we're interested to see how different clinics, kind of figure that out, and kind of what works for them, and our approach is whatever works for your clinic, however you want to integrate it, because for sustainability purposes, that's really important, right? Like if we're trying to force a system that it just doesn't fit to that clinic, they're not going to keep doing it after this grant's over. But if it's integrated into what they already do and it makes sense for them, then it's more likely that it's going to be sustainable after this leaves.
Victor, to that question, we did another demonstration of this in rural areas, and we specifically set the billing system up so that there could be multiple visits, and we thought that probably folks would take advantage of that. In fact, we found that folks compacted it into one visit because of travel problems and just logistics and that sort of thing. So I think there's actually an incentive built in to get this done as quickly as possible, if you will. And then we have these referral resources that are built in to do kind of the follow-up if that's kind of indicated.
Would you mind just repeating that a little bit?
Oh, yes. What did you say? So- no, seriously, what did you say? Yeah, how about you want to use a microphone? Is there a microphone up here? I feel like you said it so good, Scott. I mean, you can't replicate that. You know what I'm saying? Is it on already? Yeah. There you go.
We had a separate demonstration project for this in a rural area, and the idea was we actually set it up so you could have multiple visits, thinking the folks would like to take advantage of that, and doctors might like to take advantage of that. In fact, what we found was that folks actually compacted their visits as opposed to made more, and it's kind of the theory in this that they're going to continue to do that. That they'll do as much as they can in one setting, and then make the referrals into the networks that we've set up, either to the family support program for the home visitor, or if there's a more severe case, into the mental health system.
Cool. And I completely forgot I was supposed to repeat people's questions. Sorry. So I'm gonna hold this right here. Yeah. So I'm going to actually hold this onto it, so you have a question, I hand it to you. Okay, so any other questions? So it started in last year of September, 2015. Is that what it is? 2015, and it runs to this year September. So it's a 2-year thing. Oh wait, so it's 2014. So it's a 2-year thing. Yeah. Sorry. Well, no, not directly. We don't have a direct. Okay, there you go. The Church Administration is not directly connected to this initiative. No. Yes, they know about it, and in fact, I know a lot of their folks are trained in Triple P as well. And in fact, our program was at one point actually a contractor with Church Administration. But yeah. Any other questions? Okay, and then I wanted to share a little bit about the evaluation component, just to kind of show a little bit about what are some of the things that we want to learn. So what we want to learn, what to understand, yes.
So you've mentioned that so it's been running since September 2014, but a few minutes ago you said there's only 18 to 20 primary caregivers actually participating in this. Mm-hmm. So how many people do they actually reach out?
How many people do they actually reach?
Yeah.
Like how many families?
Yeah.
Well, at this point, we're actually in the big. So they were the trainings has started in June 2015. And then we didn't train primary care providers until September this past year. Yeah, so there's been a lot of planning, right? Still a lot of time to actually implement the project. And right now we're troubleshooting about how to actually integrate it into folks' practice. We've got, I think, so far, since the beginning of the year, about 15 referrals that have been referred to home visitors. But we anticipate for that to increase as folks integrate this more into their practice and it becomes more part of their practice.
And since it's in the Pierce County basis in that, like, do you go across different counties for referrals and doctors also?
They can come from anywhere. Is that what you mean? Like, yeah. Can the referrals, people be referred from anywhere? Mm-hmm. They can. And then, but there's this research component that's only looking at families that live in Tacoma area, in the urban community. But there is families that come from other places that, get referred in our program. Okay. Yeah. Our program, one of the cool things about our program is that it's one of the probably least restrictive and the kind of services that we provide. And that's actually a huge asset for Pierce County. Most have really strict guidelines that income or just kind of the different things. We do focus on mostly families with the most need, but we actually don't have actual criteria that says you can't be served because of this reason. It's pretty open, and that's actually part of that is part of our funding stream. It comes from flexible funding from the county and from the city, but it does allow us to not be so restrictive on who we serve and how we serve them. And then, so the evaluation component is, so what it is, some of the things that we want to understand is the impact of trainings on providers. So do they have more skills? Do they have more confidence? Right? Their satisfaction around the training. Right? So overall, how do the providers feel after they go to this training? Right? And then what's the impact that the trainings have on families served? Right? So do parents feel better about parenting? Right? And they're satisfied with the services they get. Right? And then the impact on training on referrals, so the number of referrals and service linkages. So are we getting more referrals from doctors to home visitors? And are home visitors actually referring to mental health providers? And is there actual communication happening? And there's, Sue and her team are the one kind of leading this, so I don't know all the details technically, but there's also a component of it. They're doing a social network analysis to really look at those kind of linkages. How do people communicate? What works, what doesn't work, and again, looking at what can we do to make sure that different systems and different providers are communicating and working together when supporting families. And then how we plan to learn some of those things, is training assessments and surveys from the actual trainings. Right, and then the impact on training and family service, so service delivery, data collection, so through the PCS 17, and then Sue's team follows up with families through phone calls that have gone through that program, and then the referrals is just pretty simple, how many referrals we're getting or whatever. So that's kind of in a super small nutshell. There's a lot more to the evaluation component, but just to give you an idea of some of the things that we're trying to learn from this. Okay, so that's the Triple P Urban Initiative, right? And so any questions about that part? Comment? So, yes.
So are you measuring anything around maltreatment or prevention of maltreatment? Is that part of it?
I don't know. I asked Sue answer that. She's actually the PI for the evaluation component.
We would love to measure that, but kind of at a population level, we had initially hoped that we could look at doing something like replicating what they did in South Carolina, right? But we just don't have the number of families to go through to really be able to look at that in any sort of definitive way. And so the evaluation for the impact on families, we're actually really focusing on that prevention and the primary care setting to look at that, because there's been so much research that's been done already for children and youth that are kind of getting the more intensive levels of service. So just really wanting to understand what the impact is for them. So we're looking at reduction in child behavior, but we're also looking at our parents reporting that they're feeling more confident in their role as parents. Are they feeling less stressed in their role as parents? Are they feeling more connected to their community, a community of supports in their role, in their parenting role? One more question. Stress, confidence. Can't remember the fourth one. It's off the top of my head. I'm getting over a cold. But so we'll kind of get at some proxy variables or things that we know are associated with maltreatment, but we're not going to look specifically at CPS referral rates and that kind of thing, just because we don't have the capacity to do that within the evaluation right now.
Can you also remind us what the dimensions are?
Yeah, it's a pretty broad measure. It's internalizing disorders, externalizing disorders, attention problems, and then there's a total scale. But you have to imagine only about 20%, maybe 30% of kids are actually going to screen positive, because these are kids that are coming in for well-child visits in the pediatrician's office. So we're not really expecting that there's going to be a huge dramatic change, because most of the kids should look pretty healthy when they are getting screened. So what we can do is we can look at the item levels and see, because every parent struggles with some things that are on that list. I don't know if anyone has ever seen it, but they're all just really common things that we all struggle with as parents. And so we'll be able to look at just item level changes and see if we can link that to use of tip sheets and advice that they get from their pediatricians.
Any other questions about that part? So as you can see, evidence-based programs are pretty awesome, right? Not so fast. So I want to share kind of a different experience. It's kind of way different than this triple period initiative, but about my own personal experience, kind of working with evidence-based programs from a grassroots community organizing perspective. So as I mentioned before, I grew up in Skagit County. It's a rural community. And I spent a lot of my early years organizing around different kinds of social justice issues, like farm worker issues, to environmental justice issues, and also to working with students in the middle school and high school around culturally appropriate, teaching in schools, and just making sure that the systems really served, the diverse students that were attending there, right? And so we did a lot of kind of community organizing. We did all the kind of common organizing tactics, like taking over school board meetings and doing protests and having walkouts from the schools, right? And just kind of did a lot of community organizing and invested a lot of energy. And then we got to a point where it was like, man, you know what? It's just like we're spending so much energy just trying to convince these systems to serve the Latino community. And it's so much energy to doing that. Like instead of spending our energy so much on trying to convince them about what we need, let's create something for ourselves. So me and a couple of us co-founded an organization called Centro Tonali. Centro Tonali was a grassroots organization that was focused on empowering the Latino community through culture, organizing, and really reconnecting to our indigenous roots as a pathway to health, as a pathway to motivating kids to attend school, to attend higher education. So we founded this organization, Centro Tonali, and a lot of our programming was community-based, right? It was what the community thought was needed. But it takes kind of some money to run a nonprofit, right? So we were like, we got to find some funds. And then there was a grant that came out that was funneled through the school district and the community college. You might have heard it called Gear Up. I don't know if you guys heard of Gear Up, right? But it's basically a grant that helps kids, work towards a college career. So we're like, all right, we'll apply, and so we actually got the grant. But of course, like many grants, you had to use evidence-based programs to reach the population, right? And so I don't remember what the exact program was, but it was like a parenting program, and then it was a program for youth, and then it was like a tutoring program. And what we found, that it was really hard to get youth and parents engaged with it. It was just really hard. Whereas other programming that we did wasn't as hard to engage in because we already had a relationship with them. So it was really hard to engage the community around these programs. And the reason is because it came with the assumption that we already knew the answer, that there's a program that was researched some faraway place that says this is what you need, right? And it didn't fit to the complexity that is within a community. So we spent a whole year trying to get people to come to the tutoring. We spent a whole year trying to get parents to come to this, and we had some pockets of success, right? But it wasn't nearly what we expected. So we actually started pushing to gear up and say, hey, this is not working. This is not what the community wants. This is not what the community needs. But of course, they were like, it is what it is. If you want the money, you have to use programs that we know work. So we're like, all right, so you're not going to pay us for this, so we're just going to do it on our own, like other things. So what we did is that we used a community-based participatory process where we did house meetings. So we chose about 10 families who were already kind of really involved in the community, and we said, hey, you go find 10 other families that you know and organize them and have them come to your house, and we're going to do a presentation about Centro Tonali, the things that we're doing. We're going to ask you what's important to you. What's going to get your child to go to school, right, and go to college? So we did a bunch of house meetings around that. And then after we finished, it was about 30 or 50 house meetings, and we reached about 200 people, and it all led to a community assembly. So we reached all these communities, and then we asked them, what do you care about? What do you think is going to help you and your family be healthy and be involved? And what we found that what they wanted had nothing to do with school. It actually what they wanted was a soccer league. And the soccer league, they wanted it because a lot of their kids were actually really good at soccer, but the coaches wouldn't play them. And the reason, according to parents, was because of racism and discrimination, right? And so they were like, we need our own space where our kids can play and where we can get involved. I can't get involved in the current soccer league because one, it's really expensive, and two, they don't have any Spanish-speaking coaches, and it just doesn't feel like a community that I can integrate myself easily. So we're like, all right, let's do it. So we started a soccer league called La Liga Tlashli, right? And we did a bunch of car washes. We did a bunch of things to fundraise money to buy everyone their first uniforms, right? And then we went out and fundraised money to actually pay to get registered into the association and to pay for the fields and do all these things. And parents decided that they all came on board and we're all going to help, and they all did. And so the board was made up of parents. And it ignited this energy in the community, right? And we used that as a way to engage in more conversations about education. So kids really wanted to go to play soccer, right? And parents really wanted their kids to play soccer, and parents also really cared about school. So we started making a connection with teachers. We started saying, hey, just like in the other sports do, right? If you want to play in the soccer league, you have to have a C average, right? If you want to play in the soccer, now you have to come to tutoring after school, right? And so what we saw is that actually what worked wasn't really the evidence-based programs, right? It was actually the community with their idea of a soccer league, right? And it increased the kids that were going, that actually, so we had a bunch of kids join, and out of those kids, we worked with certain families that wanted to participate, and we followed them to see how their grades were impacted. And granted, we had really, really like minimal kind of capacity, right? We didn't have any research experience. We weren't like researchers or anything. But we could access people's grades. So that's the way, that was our rigorous research, right? Is that if we saw a kid's grade increase, then we saw that as a success. So what I learned from this kind of this experience was that sometimes EvidenceBased can be a barrier to community-driven efforts because they come into communities assuming that they already have the answer, right? And can discourage community innovation and creativity, right? Because the answer has already been developed, right? And it kind of misses out on community wisdom and community leadership. So the evidence-based programs that we were trying to implement didn't allow for parents to come up with their own ideas, right? It didn't allow for them to take ownership of it because it was already a set way of doing it. You had to do it this way to keep fidelity, right? Whereas in the soccer league, and there was other programs that came out of it. We also had an art program that came out of that, right? And we also had like a car. So a lot of kids were really interested in building cars. So there was parents that came together and started teaching kids how to build cars and how to build lowriders, right? But what we did is we started saying, okay, we come and work on lowriders, and here's some options about mechanic careers or careers related to building cars. But those things weren't possible within the framework of evidence-based programs, right? So I guess what I learned through this process is that evidence-based programs are great, but also too, if you're out trying to kind of support community, it's really important to find room and find space to build on community wisdom and community leadership, and it's actually more sustainable. So that soccer league was founded in 2006. That league's still going on today. Guess those evidence-based programs that they were there, you think they're there? No, they're not. They're gone. Right? But the soccer league's still there, and it has served in its 10 years, up to thousands of kids now, right? So I feel like for me, I really value evidence-based programs, and I also kind of I'm careful about how to implement them in community, especially in the context of community-driven efforts, because it could really hamper the leadership potential and creativity potential, and kind of doesn't build on the wisdom that's already there. So I wanted to share that experience because I felt like it's valuable when we think about implementing evidence-based programs, and what that means to communities, right? And how that may come off to communities, how it might come off to communities. So yes.
Knowing your experience in Skagit County, could you share how that might influence or how that might have, influenced your work in the Tacoma Pierce County initiative?
Yeah, so actually, we got really lucky that and at the same time that we're doing Triple P, we also got another grant. That's actually really awesome grant. It's called Making Connections, and it comes from the Prevention Institute. And the grant is for a community-driven, community-level strategies to support mental health. It's not direct service. It's not us saying, hey, this is what Swisher says works. It's, hey, what do you need, or what's important to you? What do you think is necessary to be in place to support mental health for you, right? So that's how it has influenced me. Is just really looking at how, one, is there funding streams that could be, can be used for that kind of work, and two, just building and working with community organizers and community partners, and really listening to them, and building rapport with community members. It's actually challenging to do that. So one of the things that we're doing with the Tacoma Pierce County Health Department is that when you use an equity and social justice lens, right, things get really complicated, but they become more meaningful. Right, so one of them is doing community engagement and having a community-driven process as a representative from an institution that historically has been part of the problem, right? Has been part of the institution that has marginalized communities, right? So it's been a challenge trying to understand what government's role is in community-driven efforts and community-level work. But we know that it's an important relationship to figure out, right? So some of the things that we've done to try to kind of explore that is that we really are doing a community-driven effort, but then by the nature that the health department got this money, it's problematic. So for one, we took half of the money, right? So because we have like a huge indirect, so we got this grant, and we're saying, hey, it's community-driven, so we're gonna take half the money, here's the other half, and you all kind of figure out how you wanna spend that. So off the bat, we're already like taking a lot of money, and that creates problems, right? And then the other is that inherently, because we're the funder, then there creates power dynamics within the community, right? So what we've done is that we've acknowledged that, and so in our community planning meetings, we actually came up with community agreements. And one of the things that the partner said that needed to be up there as a community agreement is for the health department to acknowledge that it's in a position of power, and that to keep that in mind as we come together as a table, right? To keep that in mind that the health department has institutional power and influences that process in ways that maybe community partners don't have. I don't know if that answered your question or not, but kind of. Yeah. Any other questions or comments?
Hello. Okay. I think your story of the soccer league is really compelling. And one of the reasons that it, I think, probably worked so well is you provided a really clear incentive and disincentive for behavior change for the kids, right? So they wanted to go to soccer, they had to do well in school, which meant that they had to show up at school,
Right.
they had to do their homework, those kinds of things. And so I can totally see where an intervention like that would be incredibly powerful and effective within a community. I'm kind of wondering in my head what advice you would give for some of the more kind of mental health related interventions that maybe don't have such a clear correlate, where you're not kind of activating behavior in a certain way or reinforcing it in that same way, but you're, kind of the interventions are designed to help address cognitions or thoughts that kids are having that they're really struggling with and those kinds of things. Do you have other, like an example or advice that you might give to people who are developing those programs that maybe don't have that same leverage point?
Yeah, I don't think I have a clear answer for that, I'll be honest. I do know that some of the things that we did around, and it wasn't just the soccer league, it was doing other cultural relevant things, like we did sweat lodges. We also did spiritual runs, and we also went up to the mountains and had elders come and do ceremonies around that. So for Latino youth, right, part of and this is kind of our perspective, that part of achieving mental health required a process of decolonizing our minds and reconnecting to our indigenous roots and to our cultural roots, right? And part of that was going to sweat lodges. We also started an Aztec dance group where it created a space for spiritual growth and exploring their spirituality, which we know is an important part of mental health and well-being, right? So I think
That's actually really helpful clarification. Thank you.
But I think that that's one of the challenges is working within systems and trying to function around that while working with community. It seems they're almost like at odds in a lot of ways, right? And I think that's the question. How do we make sure that our systems support what's already there, right? How do we build on cultural practices, for example? And how do we do that in ways that don't waste money or resources? Because I think one of the reasons why you have evidence-based programs, because at one point people were just doing things because they thought it was great, or there wasn't accountability. So the response is, well, we need to do things that we know work and that we know are gonna give us a good bang for our buck. So there's kind of like this tension of like, how do you do that? And I don't have an answer for that, but that's kind of how we approach that. Yeah.
I don't want you to go, so I'm going to think of some more questions.
I think we have a couple minutes.
Okay. So I totally get it, but from my experience, I work with EBPs that are aimed toward families that have been disengaged from community. It's difficult to uncover their roots. I mean, they all have communities that they've come from, but I'm just wondering if you have any tips for those of us who need to go into someone's home, and it's really tough to identify who the opinion leaders are and who they talk to, who their associations with.
Yeah. So some of the people that I worked with while I was there was kids that were involved in gangs, and the kids that were really involved with gangs oftentimes came with families that you talked about, that there was substance abuse in the home, who were Latino themselves, but not necessarily integrated in the community, right? So those kids weren't participating necessarily in the soccer league in the way that other kids were participating, right? So for those kids, it was a different approach. And it was a more targeted work. So we started a program called Tepochcali. And Tepochcali is a Nahuatl word that means the house, the schoolhouse. This is basically like the Aztecs had it's kind of like your high school version today, right? You had the Tepochcali was kind of your high school, and you had Calmecac, which was like a university. So we started this program at an elementary school with a lot of resistance because it wasn't an evidence-based program, right? It wasn't an evidence program, a lot of resistance. And what it was a gang prevention program that had nothing to do with gangs. We didn't talk about gangs. It had nothing to do with it. And in fact, the way we recruited kids had nothing to do with gang affiliation. So the school was like, you need to pick either only norteños, so those are the blue ones, or sureños. Or norteños are the guys with red, and sureños with the red. You need to pick the one because they're going to fight. You put them on, they're going to fight. And we actually decided, no, if we do that, we reinforce and we actually push value in that. We're not going to choose people based on their gang colors. We're going to choose them on their willingness to participate in this. So we had one-on-one interviews with each of the kid, and we told them this is what we're going to do. And we did a lot of culturally based work. And these were the kids actually that had a lot of mental health issues, that were getting kicked out of school, right? That were involved in gangs, right? A lot of anxiety, a lot of depression, a lot of anger, right? And so there was a lot of angst about what was going to happen. But I think that, for those kinds of kids, it's really about creating a space that gives them just, I don't want to sound corny, but it's just like love as a basis to get into their hearts. And so, for example, the first day, it wasn't like, here's all the things we're going to do. The first day, we actually had tacos and tortas for the first day, and we just sat around and we ate, and we just got to know each other, right? And then we also incorporated experiential education. So a lot of the kids were really kind of, at that age, adolescents are in general, everyone are really prone to like risky behavior. So we instead of trying to suppress that, we actually encouraged it and provided a safe space to do that. So we took them to a ropes course, right? So you had these badass OGs, gangsters, like scared because they were in the high ropes course, right? And then but it created community. And I actually have a story about a time where, and again, this wasn't an evidence-based program. We didn't have like a rigorous evaluation, but there was these things that the people that were involved in the program saw the impact. And one of them was, well, for one, there wasn't a single fight through the whole year, right? And two, when we interviewed teachers about the climate in school, is that the tension around the gang actually was reduced. And the kids actually improved their grades. They didn't start getting A's, right? But they nevertheless, their grades improved. Each program at the end of the year, we also had a rites of passage as a way to get it. So it was eighth graders and rites of passage that went to high school. And we took them out to the mountains, to Mount Baker. And we sat around the fire and we had talks. And one of the activities was going whitewater rafting. And so we were going whitewater rafting. A lot of these kids have never even been to the mountains, never been whitewater rafting. Actually, I had never been whitewater rafting before, right? So we were going down the river, right? And at first it started kind of slow. So the kids were like, man, this is it, this is whack, man. I thought it was gonna be like super scary. So the guy, the lead was like, just hold on, it's gonna get more crazy. So we started going down, and then sure enough, it starts getting all like, we hit this huge like rock. So we hit this huge rock, and one of the kids, all I remember is just like splash everywhere, and I look back, and the kid fell over into the river, and I was like, holy crap, I just like lost somebody's kid. I flipped out, I was so scared. And then there was two boats, and the other boat came back, and luckily, was able to pick up that kid. And then it was a rival gang member that actually reached out to give him the hand and pulled him up, and then I was kind of emotional when I tell the story because it's like it really impacted me. But we pulled over to the side, and you have to remember these are like tough like gangsters that don't show emotion. In fact, showing emotion is like a sign of weakness. And I remember we sat there and it was quiet for like 3 or 4 minutes, and this young man was crying. He was really scared. And then everyone just started giving him support, and they were like, hey man, it's okay, homie, it's gonna be fine. And nobody judged them, and then when we come back to school, nobody talked about it. Nobody said, oh, he was crying or made fun of him. And it just created this bond with those students that transcended gangs, and that years later, kids came up to me and said, hey, you know what, I still remember that time, and I remember that really meant something to me. And it changed my life, So I feel like, there's those broad strategies, that soccer league can reach a lot of kids. And then there's those kids or those families that really need that one-on-one kind of support that's driven by love and support, and just creates a space, for that love, which can happen within evidence-based programs, right? It can. I think sometimes the evidence-based programs might not highlight that as much when training providers, right? It's really technical. And so, some of the things that we do with family support workers is we train them on that, but we also provide space to cultivate that spirit, right? So I don't know if that answers your question or not, but that was just a story that sticks with me, about the power of love, So.
Thanks, Victor. That was really powerful.
Thanks.
So I think we have
That's
to
it.
end if there's no other pressing questions at this time. But Victor will be here, I'm sure, for a couple more minutes to answer any follow-up
Yeah,
questions.
so here's my email too if people want to email me. All right, well,
Thanks
thank you for
very much.
coming.